First of all, I would like to start by thanking the organizers for giving me the opportunity to present our work here on antibody signatures and clinical associations in adults with long COVID compared to recovered controls. First, I'm going to present our study cohorts. We have 426 participants that had long COVID, 241 recovered controls. The long COVID cohort was followed longitudinally, while the recovered controls were cross-sectional, and both of them were from cohorts from Catalonia in Spain, and the two cohorts were matched by sex, age, days since onset of symptoms, and vaccine doses. This is the sampling scheme. It started in November 2021 and ended in November 2023 with up to 6 visits and spanning different variants of the SARS-CoV-2. And the recruitment of the new participants took place during the four visits of the study. So to simplify the nomenclature, I will talk from now on about time points. And the first time points of our participants in the long COVID cohort, the characteristics of these participants were the ones used to match with our recovered controls. So up until now, we have generated data for these time points that I'm highlighting here, and we have performed an in-depth immunological profiling of our subjects. We have measured total antibodies, also specific antibodies to SARS-CoV-2 antigens and different variants of concern, and also specific antibody responses to different pathogens. Also cytokines, autoantibodies, cortisol, coagulation factors, C1q, and T-cell profiling. And by the way, if you are interested in the T-cell profiling, Gemma, my colleague, will talk about this in the next session. But for now, in this presentation, I'm going to focus on the total antibody responses and specific responses to SARS-CoV-2 antigens. So let's start by looking at the characteristics of our two cohorts. As you can see, the cohorts are pretty similar, but we do see some differences. And as expected, the long COVID cohort had a higher percentage of hospitalized participants. And also, despite our efforts of matching the two cohorts, we also saw differences in the days since onset of symptoms, and also days since last vaccine dose or days since last SARS-CoV-2 infection. So in our subsequent analysis, we always adjusted by these variables when appropriate. And regarding the comorbidities, I'm showing you here the comorbidities that were comparable between the two cohorts. For the long COVID cohort, we do have more information, but since they were two different cohorts, I'm showing just here the ones that were comparable, collected in a comparable way. And we do see a higher proportion of people with hypertension or dyslipidemia, obesity, autoimmune diseases, and depression among the long COVID cohort compared to the recovered controls. Regarding the symptoms, I am showing you here the percentage of people with each of the symptoms in the first time point. And just to mention the top ones, we have fatigue, arthromyalgia, cognitive affectation, and fatigue during exercise. And at the first time point, the median number of symptoms of our participants was around 10. So let's go to our first question that we wanted to answer, which is, are there differences in antibody responses between the long COVID cohort and the recovered controls? And to study this, we performed multivariable analysis where we looked at the effect of cohort in antibody responses, adjusting by important covariables, and we looked at the antibody responses in 3 different ways. The first one is antigen-specific antibody responses, the second one is total antibody responses, and the third one, relative antibody responses. Regarding the specific antibody responses, we see a very clear pattern for all antibody responses in which they are lower in the long COVID cohort compared to the recovered controls. Next, looking at total antibody responses, we also see that they are lower in the long COVID cohort, except for IgG3 and IgG4. And regarding the relative responses, what I've done here is calculate the ratio of IgM to IgA or IgG responses. And we see that this ratio is higher in the long COVID cohort compared to the recovered controls. What this means is that the rate of, or it could mean that the rate of class switching from IgM to more downstream antibodies like IgG or IgA is lower in the long COVID cohort. And why is this important? Because class switching is part of a normal and adaptive B-cell response. Next, if we look at the independent predictors of antibody responses, regardless of the cohort, we see predictors like age that was positively associated with nucleocapsid responses, but negatively associated with IgM responses. We also see that being male is associated with higher antibody responses. As expected, also hospitalized and previous infections were very positively associated with higher antibody responses, and also vaccine doses. We see that days since the last dose or days since last infection is associated with lower antibody responses due to the antibody decline. And interestingly, we see a weak but consistent association of IgG responses, negative association of IgG responses with depression. Our next question was which factors can predict antibody levels among the long COVID participants? The first thing we did was perform a PCA to group our antibody responses, and we saw very clearly that IgG and IgA responses were clustering together and were contributing mainly to the principal component 1, and IgM responses were clustering together and were contributing to the principal component 2. Next, we performed a lasso regression and selection of our variables, and then we looked at the variables that were more repeatedly selected as important ones, and finally we performed a final model. And we saw positive associations with antibody responses to the principal component 1, and we see like two patterns. Some positive associations of variables that are representative of a more severe infection, like older age, having fever, a higher body mass index, hospitalization, or loss of smell or taste. And others that are representative of exposure, like vaccine doses or number of infections. And as for negative associations, we have taken any drugs in general for chronic conditions, and in particular, drugs that have an effect on the immune system. And also, we see that the days that have passed since the last COVID infection has a negative effect, and also having sore throat during the first COVID infection was associated with lower antibody levels. Maybe it's associated with a more localized immune response. And none of the variables was selected as predictive of IgM responses. Next, we looked at the antibody levels at time point 1 and whether they could predict the clinical trajectory of our participants. We can look at the clinical trajectory in different ways. We can look at the number of reinfections, quality of life, number of symptoms, medications, or new diseases or diagnoses during the follow-up. We first looked at the reinfections, and we saw that our antibody levels, all IgA responses, could predict and were associated with no reinfections or the absence of reinfections during follow-up, and IgG responses to S2 and nucleocapsid were also associated with lower odds of reinfection during follow-up. Then we created a composite clinical trajectory index considering the quality of life reported by the participants, the number of symptoms, the drugs that they were taking, and the diagnosis that they took, all adjusted by the days of follow-up to be able to compare between participants. And we saw that our antibodies to S2 and to N full length and the ancestral RBD were associated with a better clinical trajectory. And finally, we wanted to look at the kinetics of the antibodies in our cohorts, and since we didn't have longitudinal data in our recovered controls, we looked at the time since the last immunity boosting event, like infection or vaccination, and we compared these two cohorts as a whole. And what we see here for the antigens that I am highlighting here with a circle is that in the long COVID cohort, the orange one, there is a steeper decrease in the antibody levels compared to the recovered controls initially. And coincidentally, some of these antibody responses were the ones that were associated with a better clinical trajectory. So just to finish, the take-home messages of this talk are that antibody magnitude is lower in long COVID participants for specific and total responses. There is a higher IgM to IgG or IgA ratio among long COVID participants, which suggests impaired class switching. Higher baseline IgA and IgG to specific antigens are associated with fewer reinfections and a better clinical trajectory. There is a steeper initial decrease of antibodies in the long COVID cohort compared to the recovered cohort, and these patterns altogether point to an immature humoral response in individuals with long COVID. Finally, I would like to acknowledge the team, the huge team that has been involved in this study, and of course the study participants and all of you for listening. Thank you.